So thank you very much for joining us this evening for our collaborative forum. Tonight's presentation is about opioid use in older adults, the ideal and the actual journeys. I'm Kathy Scrimshaw. I am the medical director of the Collaborative Mentorship Network for Chronic Pain and Addiction, and it's my great pleasure to have our speakers, Dr. Lara Nixon and Mareiz Morcos. So first of all, the usual housekeeping. I am a paid employee of the Alberta College of Family Physicians. I have no other disclosures. My colleagues here tonight, Dr. Leah Phillips, Carrie McNabb, Maya Mudrick, and Jared Leader are part of the CMN team, and they are paid employees of the Alberta College of Family Physicians. This program receives some financial support through the Alberta College of Family Physicians through a Health Canada Substance Use and Addictions Program contribution. It does not receive in-kind support. And to capture your attendance, please click on the survey link in the chat to enter your name and email, and we'll put that up a couple of times during the night. We'll be using the chat function tonight to collect questions, but also comments and suggestions for various questions our speakers are putting through. So please feel free to use that chat function. We've got a couple of polls, and please try to enter your responses there. And I think most people are used to those. And also at the end of the session, please use your raise hand feature to verbally ask a question. And we do have a dedicated time for Q&A at the end of the session. The evaluations are really important. Please try to fill those out, and we'll put a link in the chat for those as well. And so I'm going to introduce our two speakers. So Lara Nixon is an academic family physician. I don't know where that dinging is coming from, working in outreach team-based inner city care, primarily with older adults with experiences of homelessness. She does research on health equity, integrated inner city health and social service innovations, grounded in close collaboration with her community partners, including service users, providers. She has several grants, and she's very interested in advocating for more vulnerable populations and older adults, and will be very interested in getting your opinions on some of those during the night. Our next speaker. Oh, if we can go back to the bio, Mareiz. So Mareiz Morcos is a PharmD from Edmonton. She's been a pharmacist that's practiced both in acute care and in community for the last 15 years. She has been in continuing care and acute care. She's a leadership cohort member, a member of, or a speaker for the Alberta Pharmacist Association, actively involved in deprescribing initiatives at the University of Alberta and at McGill University. She's been a peer reviewer with the Canadian Journal of Pharmacists, and she has multiple skills and enhanced skills through her pharmacy training. So we're looking very forward to her expertise in managing opioids in older adults. And so now I'm going to turn it over to our two speakers, and please take it away.
And thank you so much for the opportunity to share some of our ideas and learning today, and hopefully create a forum for lots of that with yourselves tonight. I'm an associate professor with the University of Calgary, an AHS and Alex employed physician, and I have received an honorarium for this talk from the College of Family Physicians.
Hi everyone, I'm Mareiz Morcos. So I work for a long-term care facility, and I also have affiliations with the Waterloo University and University of Alberta. And I have received an honorarium from the Alberta College of Family Physicians for this presentation.
And I'll just hand over to you, Mareiz.
So welcome everyone for today's session. We would like to start off our presentation by sharing with you our objectives for the session and what you hope to learn from today's session. Then we will review some stats on how chronic opioid use is becoming a crisis, even in older people. And we'll take you over a patient journey and discuss what would be an ideal care versus an actual care. And we will finally conclude by discussing the chronic pain and concurrent opioid use disorder. So we have a patient case here. George is a 62-year-old self-employed house farmer, new to your practice. He has multiple work-related injuries over the past 25 years with long-standing back and shoulder pain and inadequate relief from maximum Tylenol, naproxen, and gabapentin. He tried his friend's hydromorphone, which allowed him to continue working, but then he re-injured his back and pain became out of control. He couldn't work and he defaulted on his spousal support, court order to pay, sold work truck for funds and housing at risk. He requests prescription for hydromorphone for lower back pain and to return to work. How confident are you feeling today in helping George to manage? If you can please use the poll and choose either very confident, confident, neutral, not confident, or very not confident. So I'm seeing a lot of people are more towards the neutral part. A lot of confident, not confident, but very little, very confident, and almost no, very unconfident. So more like neutral. Thank you for that. So by the end of this session, we hope that you would be able to critically reflect on older people's experiences in accessing appropriate pain management supports, both pharmacological and non-pharmacological, compare the principles of geriatric patient-centered care and harm reduction, and describe strategies for reducing opioid-related harms within our care system environments, so looking beyond individual risk-taking behaviors and identifying opportunities for harm reduction across care contexts, like in the office, in the pharmacy, emergency department, hospital, or long-term care. So we would like to hear from you what your objectives are from today's session. If there is anything else you would like us to add or discuss, if you can please use the chat text box for that. So in Canada, almost 44% of people older than 55 have used a prescription opioid, and about 1% of that group have done so daily or almost daily in the last year. Though the proportion of people starting opioid use in Canada has trended down from 2013 to 2018, older people over 65 have consistently received more new opioid prescriptions and have a higher proportion that go on to long-term opioid use. So almost 25% than any other age group. 2% of older people, 65 years and older, reported non-medical use of prescription medication. So as you can see, opioid use is very common in older adults. And this graph is to give you a clearer picture on the proportion of people prescribed long-term opioid therapy, so for more than 90 days. And as you can see, older people over the age of 65 and even 45 to 64, they have the highest percentage. So the 65 plus, it's about 27%. And this is a recent data from CIHI from 2018. So what is the consequences of these high rates of opioid use in older adults, and why is it a crisis? So older people over 50 accounted for about 39% of death from drug use worldwide by 2015. And those deaths in older people, approximately 75%, is linked to opioid use. And in Canada, from 2007 to 2015, hospitalizations for opioid overdose were consistently higher on older people than in any other age cohort. So more than 20 over 100,000. Older people opioid-related admissions accounts for about 30% of all admissions to hospital for opioid poisoning. And the risk factors can include polypharmacy, biological changes to the body that occur with older age, and comorbid conditions. So when compared to their younger counterparts, older US veterans with opioid use disorder have higher rates of mental health problems, such as comorbid mood disorder, post-traumatic stress disorder, hepatitis C, HIV, and chronic pain, including neuropathy. In addition, opioid misuse was associated with increased odds of suicidal ideation in older adults. So as you can see, the consequences of chronic opioid therapy can result in mental health issues, hospitalization, and death. So now I'll pass the floor to Lara to talk about our ideal patient journey.
Thank you, Mareiz. And thanks for your additional objective there, Lori. I do see that about managing concurrent pain and substance dependence in people experiencing homelessness. Very happy to work that into our discussions later. So just to take a little break, bit of an emotional break, maybe go to someplace tranquil where everything is wonderful. This is a picture of my son, then about 7, in the corner there. And in this story is meant to evoke kind of that ideal journey, and is based on a real patient. In this case, it's Annette, who is a 72-year-old widowed woman, retired from her work as a teacher, who lives independently. She enjoys golf and racket sports and winters in Yuma, Arizona, when it's not a pandemic. And Annette volunteers in the long-term care facility near her home, and her 2 eldest children live nearby, and she sees them about every 2 weeks for supper or a game of tennis or golf if it's the season. She started having a dull, achy pain in her right hip approximately 3 years ago. She was able to continue playing golf and some tennis, and the pain in the right hip was mild and intermittent for quite some time, managing with just over-the-counter analgesics, extra strict acetaminophen, or a bit of naproxen once or twice a week. And then for the past year, her pain increased, and it required intra-articular steroid injections, which she did have some relief with. She had 2 over the course of the year. She also was prescribed some duloxetine and topical diclofenac 8% TID, and naproxen 500 most days in the morning over time. She was seen by orthopedic surgery and put on the wait list, and was hoping to be seen in 6 to 12 months. And it was her lucky day. Although she had to stop playing tennis and golf, she found exercise and swimming really helpful while she was awaiting her hip replacement. And so about 3 months ago, she received a total hip replacement for what was by then severe osteoarthritis. Her postoperative course was uneventful, and her pain was well controlled on Tramicet TID, just 1, 650 of acetaminophen TID, long-acting, and gabapentin 100 TID PRN. She was discharged post-op day 4, and her eldest son was able to stay with her for the first 2 weeks, supported by his employer's caregiver stipend. He handily equipped her home with a bath chair and grab bars and lots of ready-to-eat meals. She managed well with visiting support from her children after that, and home care for the next 8 weeks, but was then ready to have her house back to herself. She easily accessed a free targeted exercise program at the City Recreation Center in her neighborhood, and she was almost golf ready by 10 weeks post-op. By 12 weeks, she had weaned off of the gabapentin, Tramicet, and was back to taking only periodic acetaminophen 500 for her hip pain if she really overdid it, mostly playing pickleball, which she found easier and fun compared to tennis on her hip. And so I just wanted to offer up, I'm sure lots of you were excited to see the release of the new simplified chronic pain guideline by the peer group last week in CFP. And we wanted to just share this table that and sort of walk through it very briefly. And you can see that Annette had the physical activity. She had lots of psychosocial supports. She benefited from a couple of intra-articular steroid joints, a bit of duloxetine, and intermittent NSAIDs, and everything went smoothly. So we're curious, is that patient journey akin to your patient's journey? Is that typical? And we're going to invite you to share your thoughts, and if you could think of if that is typical, then we're looking very forward to hearing about what is in your practice or your community that supports that. But if it is not, we have an opportunity in a moment for you to give us your input. This is a fantastic data gathering for us. Thank you very much. Our hope is to actually compile our thoughts and ideas into over time with a couple more samplings to some advocacy briefs in Alberta Health, potentially the Minister of Health. So I think we've had rural internet access as a huge barrier. Thank you, Mary. Yes, and of course we're hearing that on the federal agenda as recognizing that that's an equity issue. And certainly I've seen lots of examples of that.
There can also be challenges with technology with some of the geriatric patients that just don't know how to use the technology. So even if virtual care is available, they just don't know the technology part of it.
I actually find it's a hardware access issue as well, Mareiz, because I have people who would have gone to the library, to the public libraries, and relied on publicly available computers. And of course, those have not been readily available for quite some time. So thank you so much, everybody, for your input here. So we wanted to just segue a little bit here to opioid dependence in older people. And pardon me, this is a really growing problem, quite a bit beyond what we would expect if it were just for population aging. And there has been an established cohort effect that people from the quote unquote baby boomer generation who are aging and becoming our older community members many have quite a different relationship with substances than previous generations. And so this is American data. We were not able to find great Canadian data or detailed Canadian data to this effect, but I thought these visuals might be helpful in looking at. So in the red line is sort of younger. Now that I'm in this cohort of 50 to 54, I'm not too sure I like this, but you can see a fairly steady climb from 3.4% to 7.2% of people who were surveyed in this national survey on drug use and health using opiates between 2002 and 2012. And these are for non-medical purposes. And then similarly in the 55 to 59 age group there. And the number of older adults entering treatment for heroin dependency nearly tripling between 2007 and 2017. And so we wanted to offer up this notion of harm reduction practice, which I'm assuming lots of people are very familiar with. But just to remind ourselves that it's focusing on the fact that people do things for a reason, even harmful health behaviors provide some benefit to people. And these benefits really need to be explored and understood in order to really understand the risk-benefit balance for people in their day-to-day behaviors and choices. Harm reduction is very much centered on pragmatism and respect for the individual and their autonomy, as well as incrementalism, right? Baby steps, celebrating every win that takes a person in the direction of where they're trying to get to. And if we think about these principles, and this was just a beautiful piece, I have the reference at the end, by Benjamin Han, who is a geriatric medicine specialist, highlighting that for people with complex physical and mental health challenges, multimorbidity, and substance dependence, harm reduction and geriatric care are completely in sync. And we need to focus on the goals of improving health, maintaining function and independence, and improving quality of life as is defined by that individual. And so harm reduction principles are really powerful and can oftentimes be very empowering for service providers and practitioners, and allow us to work in exactly the collaborative framework we would in any other health condition. But somehow I don't want to speak for anyone else, but I can sure attest to my training as and early CME did not align with these principles when it came to addiction management. And so we have systematic review underway, actually a scoping review of older people's experiences of opioid agonist therapy, predominantly methadone and Suboxone. And we're looking at this through a phenomenological lens and looking at aging with addiction, people's lived experience of this, and being an older person on OAT, and their service experiences. And just to give you a little snippet of what we're learning in that, is that older people oftentimes cite being sick and tired of being sick and tired, and being able to access treatment in the form of agonist therapy is really, really life-changing for many people. And the multi-level and compounding stigma that can be associated with being an older person with opioid dependence is quite profound. Housing, being separated from their family, life instability, feeling like you don't fit into the substance using community and you don't fit into the mainstream older adult communities. And so there's a lot of, unfortunately, a lot of isolation for a lot of people. And not surprisingly, positive service experiences are grounded in exactly what we endeavor to provide in our medical homes, in our relationship and person-centered holistic care approaches every day. And so we will come to we'll touch a little bit on their recommendations in just a moment, because we have some good fortune that there's alignment in some of the newer guidelines. I wanted to share this. I'm sorry, this is rather long, but this is part of a project that we've been working with, also with Health Canada SUAP funding, in a harm reduction setting in Calgary. And this is a gentleman with long-standing chronic pain, as well as opioid dependence. And I just think it's so telling about his experience. My doctor has been doing all the right things for me, but she's had to bend all the rules to do it. I didn't know that I could yell at my doctor like I do. I'm pretty respectful, but also pretty forceful. The chronic pain people, she phones them and they say, oh yeah, give them the pain pills. What is the difference? So she does it. But that's what I've been arguing all along. I've been saying I'm finally at the point where I'm comfortable, but there's so much pushback. My doc will say, oh no, I can't do that. And then the next week, okay, I spoke with the so-and-so, and so now I can. It's frustrating. I would have thought that the doctors would go beyond this choice model of addiction. And these models in general, look at them through my point of view. My doctor can't do anything at the point of conversation. She always needs permission. Why do you need permission? And so this is one of our community advisors, and this really resonated with me in terms of the highly regulated practice of providing opioid agonist therapy. At least historically, it has definitely changed, but there is an ethos that still, I think, persists for a lot of us. And with monitoring programs in general, just the way that these medications are monitored. And our community advisors, we've been endeavoring to come up with a wallet-sized definition of addiction. This is as a conversation starter is what was recommended by our group. And instead, we came up with a values statement, which is in our diverse community, older people may use substances for many reasons. We respect and care about all community members. And so I just wanted to share that with you, because that's really aligning with the recommendations that we're seeing from older people accessing OAT in the community. So we thought it would be interesting to just look in a little bit of parallel at some of our key resources. And again, I chose, Mareiz and I chose this peer guideline, which is really quite accessible. And in the case of managing opioid use disorder in primary care, this is not specific to older people, but it certainly doesn't exclude them. And the suggestion that we use a tool such as the Prescription Opioid Misuse Index, just a 6-item, quite simple tool to screen for opioid use disorder. I think trusting our spidey sense is often quite reliable as well. And their recommendation that this treatment be given in a supportive team primary care environment. It's been shown in the literature to increase adherence and satisfaction with the care and decrease street-sourced opioid use, which with contamination rates of up to 60–70% in street-sourced substances, I know everybody here is probably very, if not active, would probably be willing to with the right supports. The real emphasis in the 2019 guideline is on shared decision-making, just like we do in the rest of our work. And they do indicate that you could consider witness dosing, like daily dispensing, urine drug screening, sorry, that's an acronym there, and the use of contracts, but not for any punitive purpose. If a person said, oh yeah, it really helps me to be accountable to my treatment hopes and goals by providing urine sample every, randomly, just test me, doc, helps me stay on the line I want to be on. But if that's not somebody's jam, then that's not a tool that we would want to engage. And to plan for long-term indefinite therapy and counseling in addition to the pharmacotherapy. Well, we all saw people's access to counseling challenges. There was mention about buy-in, so some potential barriers, but I thought it was very interesting to compare that messaging and guidance to what is in our advice to the profession, which is not about could consider, but is rather an expectation that's quite explicitly set about urine drug screening and them being random. And I noticed that this advice to the profession was updated in September 2019. So for me and in my practice, that creates a disconnect. And I thought that was interesting and wanted to share that with the group, and certainly welcome anybody's comments or thoughts if you have them.
So Lara, it was very interesting in reviewing the peer guideline. I know they looked at in particular the contracts, and Tina was looking at both the negative and positive contingency protocols, and the Cochrane review came out as they make no difference. But when she said positive and negative, positive makes a huge difference. So some of the programs, right, that have a $5 card,
that's right, or a coupon to win a $5 Kim's card.
But those contracts are punitive, and they're viewed as a threat, and certainly that resulted in a discussion between peer and CPSA. Don't know where it went, but
okay, so
in talking to CPSA since then, they've agreed you need to do what's best for your patient.
Wonderful.
And so that
hopefully we'll see a 2022 update.
Yes. So there has been a discussion. So I just wanted to add that.
Thank you, Kathy. That's super interesting. Yeah. So I'm just going to hand this back over to Mareiz because she wants. We wanted her to speak to the pharmacy perspective.
Thanks, Lara. So yeah, pharmacists also have a guidance document from the Alberta College of Pharmacy regarding dealing with individuals using chronic opioid therapy for non-cancer pain, which involves knowing the patient, assessing drug therapy for appropriateness, safety, and efficacy, and documenting that interaction and assessment in the patient record. And we also need to check net care every time we dispense an opioid medication. So as a pharmacist in my daily practice, I need to fill out like a 2-page opioid assessment document every time I get a physician order for any change in dose or changes to any opioid medication. And I need to file that with the patient's other prescription files. So pharmacists also are held to college standards in terms of monitoring and assessing opioid therapy before we dispense opioid medications. So we appreciate all the ideas you have shared today about opioid use in older people, and would like to invite you to reflect on things that you do within your practice or things that are available in your community or system broadly to support interprofessional collaboration, or things that you would like to see that would support best practice care for older people who use opioids. So you can use the text box, the chat box to type in your comments, and we can categorize them into whether it's a practice level strategy or a system level strategy.
Just maybe while people are thinking about this, I'll offer up one that I have found exceedingly helpful in the setting in which I've worked for about 15 years, which has on-site medication assistance by a vendor from home care every day from 7 in the morning till 10 at night. And they have accepted our request to do daily dispensing of all opioids, including methadone. And that has been incredibly helpful to ensure access and safe storage of opioid agonist therapy for the patients that I see. So I would say that probably falls a little bit between practice level and system level, because it needed buy-in from the vendor as well.
The other idea that I would suggest as a practice level strategy that would be really helpful is if a patient is having a change in therapy to their opioid medication, if it hasn't been already communicated with the pharmacy where they filled their prescription, if maybe we can say indication, this drug is for lower back pain, or this drug is for so-and-so. So this way, when the pharmacist does their assessment, they feel more confident in dispensing the medication, and they don't have to keep asking the patient, so what are you using it for? Are you aware that there's a dose change? Did the doctor talk to you about it? Did he counsel you on it? It just really helps in terms of the documentation and our expectations as a pharmacist to do our assessment on our end.
In developing this talk and you teaching me, Mareiz, about the pharmacy, the College of Pharmacists requirements of your practice and your level of documentation and assessment, I was really struck, because I will usually just put a quick note in the notes to the pharmacist. That's what our EMR allows me to do, because I know they're so great. The pharmacists that I usually work with, they watch really carefully, and if there's a dose change, they'll oftentimes just preemptively check with me, did you mean to do this, Dr. Nixon? Because sometimes you're in a hurry, and that's why I'm trying to do that. But this makes it even more compelling in my mind to know that then we have this chance of having alignment in the messaging to our patients and in our practice.
Yeah, in my long-term care facility, a lot of doctors may put like an arrow up saying increase dose. Like they just put arrow up, morphine, so-and-so, or arrow down, so we know he's aware that there is a change in dose. And we're lucky in an institutional setting, we have a charting system where we can actually, the doctor can document why there is a change in therapy. But in community practice, this communication can be more struggle or barrier, because there isn't the same type of charting available in an institutional setting. So back to our initial patient scenario, if you guys remember, we just want to take your poll questions again on how confident are you feeling today in helping George to manage his opioid therapy. So if you can please vote again after our discussion from today and the information that we have shared and discussed. If you're feeling very confident, neutral, if you're the same, or very not confident. So I see there is a lot of still neutral, but also more confident than before, and more very, very confident.
Thank you for that.
So now we'll open up the floor for any questions that you may have. And if you can please also submit up to 3 key messages you would like us to compile into an advocacy letter to the Alberta Health Services or the Minister of Health that would help you improve the care of older people who use opioids. You can just do that via the chat box.
we will be downloading the chat and super interested, especially related to your enthusiastic stamping on our barriers chart.
So Lara, what would you do with your case in this individual?
Clearly, George, as a house framer, everybody familiar with that role? 62 and framing houses, it's a very physical job. And typically a person would be covered by WCB, even as an independent contractor, but I did do some sleuthing on this, and there are definitely people who fall through the cracks as far as that coverage with more casual labor situations. And in George's situation, I think one of the first orders of business is to help offset the financial pressure for him to return to work right away. He's a gentleman who's historically been very active with his work, but he's, because of pain, now in that rock and a hard place, terrible place of stuck with too much pain and not able to manage. In my mind, probably there's a role for a short course of hydromorphone to try and get him moving again, but probably not returning to work, especially operating nail guns and large objects that could fall on others and injure. So I think we probably are looking at a period of Alberta work support or some other income assistance as best we can. And this is where those 6 visits of free physio would have been fantastic. Probably some aqua therapy would be a choice if we could get him some fair entry access to recreation facilities. And definitely connecting him with, we're really fortunate in our primary care network to have a psychologist who is available virtually and for free of charge, one-on-one, 1-hour psychology visits. It's really, and he's got so much going on in his world. I would think that this would probably be a good starting point if he was game. And so that's where I would probably go with George.
Yeah, for sure. No, that's great. Now we do have some questions. I was waiting for people to type in, but I was curious because I too would prescribe a short course to just try to settle things down and get things a bit under control, especially with the toxic supply that is out there right now. So huge issue. So, so Lori Montgomery asked a question on patient manage the person-centered approach in the context of cognitive impairment in the older adult. How are you managing that?
It's an excellent question, Lori, and cognitive impairment and thinking about capacity as a spectrum and capacity to consent to surgery and be able to weigh the risks and benefits of action and inaction in something like that decision making, looking to try and really suss out where my person's capacity it still remains and where is it really challenged. A lot of the people that I see have concurrent substance dependence and they can have multiple reasons to have cognitive challenges, prior traumatic brain injury, vascular issues, toxic issues from substance use. And so I dare say that a lot of the times we'll be trying to fit in that capacity assessment in a period where the substance use is less, and that'll oftentimes be when they're hospitalized. And so seizing those opportunities and collaborating with acute care, geriatric medicine services, oftentimes helps us determine where the capacity remains and that decision making, and supporting that in as much as we can, and sometimes using, I think it's a Schedule 6, that is temporary assistance to a person's capacity. Yeah, so kind of supplementing, shoring it up. I don't know if that answers your questions, but those are some of the different strategies that we use.
That's great. Also had a question, how when you're prescribing opioids and how you assess the capacity for workplace safety.
I'm probably less equipped to answer that as a GP whose patient panel is one person is employed, is in paid employment. But I think almost a little bit like the capacity question, that can be fluctuating. And so if a person has been on a stable long-term opioid, that is the tool that is best suited to managing their pain in conjunction with the other modalities that they might be engaging in, really being mindful together about things that can threaten that capacity, and dehydration, concurrent illness, a bladder infection, a new medication. Someone inadvertently takes a cold medication that has a decongestant that's centrally acting. And all of a sudden, because of homeostenosis, we can see in our older person that that balance that we were pretty confident was there is lost. And we have a suddenly quite impaired situation, much like our people with diabetes. And we would give them guidance as to, okay, when to back off on your diabetes medications, or dial down your insulin if you're experiencing X, Y, Z, ABC. And I think those conversations, kind of those safety planning, are one of the ways I would approach. And then I would defer to Kathy and Lori and others in the audience, please.
Yeah, I was going to pick on Lori. How would you handle that?
I think the thing is, from my perspective, it's not a different question with opioids than it is with benzos and TCAs and gabapentin, and there's so, and pain itself. All of those things are cognitively impairing. So it really is, an issue that you've got to look at really globally, like, based on your assessment when you see them, like, can they walk into the office? Can they recall their pain history? Are you seeing impairment when you're actually working with them? Safety sensitive occupations are probably a little bit different. And there is Health Canada actually did, I'm just actually searching, trying to find it. Health Canada did a resource sheet for employers and for patients around opioids, using opioids in the workplace. And I'm just trying to locate it. I'll post it in the chat if I can find it.
Oh, that's excellent. Thank you so much. And I know people are probably seeing the chat, but for our speakers, they're seeing lots and lots of suggestions of what needs to happen to improve equity of care. From things like patient handouts specific to older adults, to pain pathways similar to BC, to coverage and access and transportation for various non-pharmacologic treatments of chronic pain. So we've got lots of suggestions there that echo what has been already said earlier when we were stamping madly at all the barriers that we do see. I think one of the questions I have for Mareiz is coverage for Suboxone if we're using it for pain as opposed to opioid use disorder. Is there coverage, or does it have to be different coverage?
No, the coverage is actually the same if you're using it for an opioid use disorder or for pain. So in our institutional setting, it is a formulary drug, and in community, it is covered by most insurance plans, including Alberta Blue Cross. I'm not sure though if in the community you need to fill out a special authorization form or not, where you may need to provide more information about why the patient needs to be on this. But if you have the indication for it, which can be pain or OAT, it would be covered. Okay.
Well, that's great. And I know that we're now winding down here. It's 8:28. If there's any further questions, please unmute. And I would like to just let you know about some upcoming sessions that are being offered by the CMN in particular. Next month's collaboration forum is how to do trauma-informed care, not why, but how to do it, and how to repair relationships that go wrong. We're very excited to have Kara Irwin, a registered psychologist, as well as Marie Ferrero, who is coming from the patient perspective from Alberta addicts who educate and advocate responsibility. So it should be a really interesting session about both these people's experience. So please mark your calendars. And also want to put a plug out for our ECHO for chronic pain and opioid use. And so I don't have the slide up here. Anyways, it's going to be run by the CMN, a free program where you can bring your cases, difficult chronic pain cases, opioid use disorder cases, cases that are complex in this realm, present your case and get an expert panel that include Laurie Montgomery, who you just heard, and other experts in chronic pain, and some of our interdisciplinary team members that work in pharmacy and in mental health areas in managing chronic pain. And you can get some advice and resources there. So it will be starting in April. Again, it's free and it's all learn and all teach. So it is an effort to build some community in the areas of chronic pain, substance use, and to understand each other's world. And so I really encourage you to join ECHO. Now, don't forget your evaluations. The link is in the chat there. And I thank you again for joining us this evening. I'm going to ask our presenters to hang around and we can just debrief how things went. But please join us next month and consider joining ECHO. And we hope to see you there.